Welcome, my friends, to the Bob and Brad podcast produced by Bob and Brad, the two most famous physical therapists on the internet. I am Bob, and I'm exactly one half of the Bob and Brad team. Today, my guest is an orthopedic surgeon, Dr. Brent Warner. And Dr. Brent Warner does a lot of arthroscopic surgery. He does the shoulder and the knee and even the hip sometimes. But today we're going to talk about knee meniscus and ACL surgeries and also shoulder rotator cuff repairs. So enjoy the program and you'll definitely will learn something. Welcome to the program, Dr. Warner.
Hi, thanks for having me. I really appreciate it.
We have about 15 minutes left. I would like to get into the shoulder too. So
yeah, absolutely.
Arthroscopic shoulder rotator cuff repair. So
yeah.
What is the rotator cuff and what part commonly requires repair?
Sure. So I think most people know, kind of understand the concept that the shoulder is a ball and socket joint, right? So the ball sits on the top of the humerus, so that we call that the humeral head. And then that ball has a socket that it kind of comes up against. And the socket is part of the shoulder blade. The technical term for the socket is called the glenoid of the shoulder, okay? Because the shoulder, has kind of so many degrees of freedom of motion there, part of that is because that socket in the shoulder is kind of just a shallow divot. I almost think of it like a golf tee kind of turned on its side. It's not like a deep cup that really surrounds that ball. So the ball has to be kind of balanced on that golf tee looking socket. So what really does a lot of that balancing act for us is the rotator cuff. The rotator cuff is made up of four separate muscles. The muscles all attached to different parts of the shoulder blade on both its kind of back surface and then sort of the front surface, which is deep, to your chest, or, kind of up against your chest wall. And those muscles then run out from that shoulder blade. They become tendons, and then those tendons attach to the ball. And so there's actually four separate tendons. They all kind of surround the ball. They kind of blend into one another a little bit to form literally a cuff of tissue that attaches to that ball. So then when you fire those muscles pull on those tendons, and that's what rotates and moves the ball relative to that socket in all the different directions that your shoulder can go.
So
I think your next question.
Yeah, not in the muscle itself, is it? The injury usually.
Right. Yeah, it's almost always the tendon that gets injured, and typically kind of right at the interface of where that tendon comes in and attaches to the ball. You asked, what part of the rotator cuff is most commonly damaged? So yeah, it's right. That tendon at the heart. And as I said, there's four different tendons. The one that is kind of directly on the top, kind of to the top to kind of towards the front a little bit, is the one kind of primarily responsible for raising the arm up in this sort of a direction. That one's called the supraspinatus, and that is by far the most common one that we see sustain damage and tears.
So I'm sure this depends on how bad the tear is, but can it heal on its own?
Yeah, so some lower grade tears, partial tears, more like tendonitis within the rotator cuff, we do believe that those have some ability to heal themselves. And so for those ones, we most commonly are going to recommend non-surgical type treatments. That's going to be things like physical therapy, being careful with certain activities, sometimes injections of cortisone and other things into the shoulder. And so some of those tears can, we think, heal themselves. Some tears are also, even if they don't fully heal, they can become asymptomatic. Not unlike we talked about with meniscus tears a little earlier. There's a fair number of rotator cuff, tears and other damage that is seen completely incidentally. Some studies have said, for example, an 80-year-old patient, there's a better than 50% chance that patient has a full thickness rotator cuff tear in their shoulder that might or might not be causing any symptoms at all.
Wow.
So even a tear can't fully heal itself, if we're able to make that tear asymptomatic, meaning that patient doesn't have significant pain and they have good function in their shoulder, that can be something you can live with. Once we get up into, these higher grade tears, ones that are, most of the tendon thickness or all the tendon thickness, those ones are going to be less likely to heal. But again, sometimes we can still treat them without needing surgery.
So is it okay to wait? I mean, let's say I want to see how this does, or is it harmful in some cases where you better get in there and do it repaired?
Yeah. I think the best distinction there is whether or not that tear is more of an acute type of traumatic tear, maybe. So that patient, formerly had a completely normal functional shoulder with no pain, and they had an injury, right? If they fell or had an accident and all of a sudden they have pain or they're not able to move their shoulder, we know that early surgery for that type of tear is typically going to be best. A number of studies have shown that when those acute traumatic tears become more chronic, the likelihood of good healing and a good outcome can go down. Probably the more common type of tear we see is what's considered to be more of a chronic degenerative or attritional type of tear. So that's going to be one more related to just, a lifetime of being a human being with a shoulder and using that shoulder for normal everyday things and work and so on. Those ones do not necessarily need immediate surgical intervention. And a lot of those it can be treated successfully with good physical therapy, with injections, with pain medications, those types of things. There are maybe a couple of exceptions to that. Some very large tears, we don't like to let those necessarily go for a long time without surgery, because some tears left long enough can actually become irreparable, meaning we can't fix them anymore. If that tissue becomes, too scarred or too damaged or too retracted, meaning it has kind of pulled so far away from the ball, we're not able to get it back where it needs to go. Sometimes those can get to a position where they're not fixable anymore. And oftentimes, if you get to that situation, that patient's not going to have a very good shoulder, a shoulder they're very happy with. So some of those we do tend to maybe be a bit more upfront thinking about surgery for.
So in that case, that kind of leads me to my next question. If you got, is there times you got to really stretch on that muscle to get it back reattached?
Yeah, some of these more chronic tears, if they've been there quite a while and things have started to kind of scar, sometimes it can be a fair chore in surgery to be able to mobilize that tissue and get it back where it needs to be. Sometimes that's not too difficult. Other times it can be, a real bit of work, and there are some kind of, subtle little tips and tricks and other strategies that we'll employ sometimes to help better mobilize that tissue. And it's one of the things that I'm always kind of prepared for. And I also kind of look back at very thankfully to like my fellowship training, that extra year I spent kind of subspecializing in this sort of thing. Some of those surgeons I learned from, they, with who they are and kind of they're the big names in my world. They would see kind of the worst of the worst and the most complicated, and being able to learn some of those advanced techniques and tips and tricks has really saved my skin, more than once. Knowing how to do some of those things, we've been able to get great results for some patients with some pretty extensive injuries.
Well, with a real tight muscle, would that throw the biomechanics of the shoulder off a bit? Not really.
It can sometimes. Muscle thankfully can be pretty forgiving. And so we will see in some instances where muscles can kind of, stretch back out, I guess is the best term to put it. But you're right. Sometimes if a person has had a lot of tendon loss, right, where typically the tendon is going to have, a couple of centimeters of length to it. If that tendon has become damaged and shortened and we have only a very small, stump left to work with, you're right. Sometimes if we try to repair that directly, we can actually kind of over tension things, make things too tight. And that can lead to stiffness, to pain, to other things. And so it is something that I tend to try to be as careful about as possible in surgery, not wanting to over tension or over tighten someone's joint. I'll admit sometimes that can be a little bit difficult.
So is this a painful surgery?
Yes, this one actually is. I've had more than one patient, who's had a variety of number of surgeries tell me that their rotator cuff experience recovering has been kind of amongst the hardest of them. Now, I think similar to what we've kind of done with ACL surgery and other knee surgeries, I think we have seen some real advances in this, especially over the last couple of years. Similar to what we do for an ACL surgery, that patient's going to be under a general anesthesia, and we're going to do some form of a regional anesthesia, a block to numb the nerves that kind of go to the shoulder and the arm. With the shoulder, we're actually able to do a long-acting form of that block. So a medication that's going to last for typically the first 2 to 3 days after surgery. And we've been doing that now here at Summit for the last, 4 or 5 years now, I think.
Sure.
And it has, in my mind, been a real game changer for people and their experience recovering from this surgery. They tend to get really nice relief of kind of the most severe pain for that first 2 to 3 days. I think that sort of resets the bar a little bit for kind of what their expectation is and what their body has to sort of, overcome to kind of get through that. And so I've seen people, coming back to see me for their first follow-ups in a week or two saying that they took, almost no pain medicine at all, or just took it for a day or two. Whereas I think with more classic techniques, it was not uncommon to see people still wanting to take pain medicine even 2 and 3 weeks or further from their rotator cuff surgery. So it has certainly been a good thing in our practice here. Patients seem to be really liking it a lot. And I think anything we honestly can be doing to minimize the number of strong pain medications people are taking, I think that's a really good thing, both for their health and just sort of public health in general. We know narcotics are dangerous drugs, and they can unfortunately get into the wrong hands, even sometimes with the best of intentions, and can cause all sorts of serious troubles. So if we can, be good stewards of that and minimize the number of those we're using for people, I really think that's an important thing.
All right. I want to be very respectful of your time. So I'm going to mention your website again and how to get a hold of you, Dr. Warner, in case you want to have surgery from him. So the best way is summitortho.com, SUMMITORTHO.com. And he does, do you do hip surgeries too or not?
I do, yeah. So I do arthroscopic hip surgery. So similar to, in the knee or the shoulder, we can use a tiny camera to guide down inside of the hip joint. And there's a number of different things we can accomplish with that sort of a technique. So yes, I do hip arthroscopy, or do arthroscopy of all 3 of those joints.
How about elbow?
I don't do much elbow. I have several partners that are more kind of subspecialized to kind of the elbow all the way down to the hand and wrist. And so most commonly, I'm going to kind of pass those patients along to those specialists.
Well, thank you again, Dr. Warner. Very impressive, great information. And hope some people will check you out because you're in that zone. You're a lot of surgeries, but you're young. So,
yep. Yeah.
All right. Thanks.
No, thank you so much for having me. It's been fun. I really, really appreciate it.
Yep. Thanks for being on.